Picture this. You're in the middle of a busy ICU, and a ventilator alarm suddenly slices through the noise. What's your first move? What's your second? Today, we are going to walk through a super clear, life-saving framework for that exact moment. We're going to talk about the golden minute.
Okay, let's just start with the most important principle of all. This is the one thing you absolutely have to burn into your brain. Ventilator alarms, they are not background noise. They aren't just beeps. They're a signal, a crucial piece of communication that something has changed.
But look, let's be real. Alarm fatigue is a huge problem. When you're hearing those sounds all day long, it is so easy to start tuning them out. But missing the one alarm that really matters, well, that can cost a patient everything.
So that's the big question, isn't it? The second that alarm starts blaring, a clock starts ticking. This whole explainer is about how you can own that first critical minute with a calm, systematic, and most importantly, effective plan.
And that plan has a name, the Golden Minute Rule. Think of it as your immediate actionable pathway that cuts right through any chaos or panic.
All right, here is the absolute game changer. Your very first move in the first 10 seconds is always to look at the patient. Not the ventilator screen, not the buttons, but the person. Are they in distress? Is their chest rising? What's their color like? The patient tells you how serious this is way before the machine ever can. And sometimes, looking at the patient gives you total permission to just act. If you see any of these signs, if they look unstable, their sats are plummeting, or you hear that high-pressure alarm but see zero chest rise, you don't troubleshoot. You disconnect them from the ventilator and you start bagging them with 100% oxygen. That one move does two things. It saves them, and it tells you instantly if the problem is the patient or the machine.
And that number? That's your clock. 60 seconds. That's the window you have to assess, decide, and intervene. It's not a lot of time, which is exactly why having a system isn't just nice to have, it's absolutely essential.
And here it is. This is the system. It's a simple, non-negotiable order. Patient first, then the tube, then the circuit, and dead last the ventilator itself. Following this order every single time builds the kind of muscle memory that saves lives when things go sideways.
Okay, let's dive into our first big scenario, the high-pressure alarm. When you hear this alarm, I want you to think of one simple word: blockage.
The machine is basically screaming at you, "Hey, I'm trying to push this breath in, but something is blocking my way." It's hitting a wall of resistance that just shouldn't be there.
So what is that wall? Well, it could be a bunch of things. Maybe a simple kink in the endotracheal tube, or the patient is biting down on it. It could be a thick mucus plug, the patient coughing, or even a bronchospasm. Or it could be something more serious, like their lungs are getting stiffer from something like ARDS, acute respiratory distress syndrome, or even a new pneumothorax, a collapsed lung.
So what do? You go right back to your system. First, look at the patient. Are they agitated? Then run your hand along the tube from their mouth outwards. Any kinks? After that, try to pass a suction catheter. This is a great move because it doesn't just clear out a potential mucus plug, it also proves the tube is open. Finally, throw your stethoscope on their chest. A quick listen can give you major clues about what's going on.
Now let's flip the script and talk about the polar opposite. If high pressure is a blockage, a low pressure alarm means only one thing: there's a leak somewhere.
This time, the ventilator is saying, "I'm pushing this breath out, but it's escaping somewhere. It's not all getting to the lungs." All that pressure that's supposed to build up is just vanishing.
Your job is to become a leak detective. Often, it's something simple, like a connection in the circuit came loose. But it could be a leak in the cuff of the ET tube, or, and this is the one that should really get your attention, the tube has been partially or even completely pulled out.
So your 60-second action plan is a rapid search. Start right at the patient and physically trace the tubing all the way back to the ventilator, checking every single connection. Check the cuff pressure, and most importantly, look at the number marking on the tube right at the patient's lips. Do you remember what it was before? Has it changed? A sudden low-pressure alarm means you have to assume accidental extubation until you prove otherwise.
Let's just pause here for a second, because this is so important. If you only take away one thing, let it be this. High pressure means blockage. Low pressure means leak. Just burning this simple idea into your brain is the foundation for calmly dealing with almost any ventilator alarm you'll ever face.
Okay, so we've talked about the mechanical stuff, the blockages and the leaks. But what happens when the alarm isn't really about the machine at all? What happens when it's a direct signal from the patient's own body? It's so easy to hear that high respiratory rate alarm and just think of it as a nuisance, right? Something you need to silence. But you've got to flip the question around. Ask yourself, why does my patient feel the need to breathe so fast? What are they trying to tell me?
That rapid breathing isn't the problem. It's a symptom of a deeper problem. Are they in pain? Are they anxious? Are they not getting enough oxygen? Or is it a sign of something much bigger, like metabolic acidosis or the beginnings of sepsis? This alarm should trigger a clinical investigation, not just a knee-jerk tweak of the ventilator settings.
And listen, this right here might be the single most important warning in this whole explainer. The easy fix is to just turn up the sedation to slow their breathing down. But if you do that without figuring out why they're breathing fast, you're not fixing the problem. You're just silencing the person who's desperately trying to warn you about it.
So let's pull all of this together. This isn't just a list of things to memorize. The goal is to make this a mental flowchart that becomes second nature, something you do automatically right at the bedside.
And this is it. This is the whole flow. The alarm goes off. Boom. Your eyes go straight to the patient. You check their vitals, you watch their chest, you make that critical call. Are they stable enough for me to troubleshoot, or do I need to disconnect and bag them right now? Only after you've made that call do you work your way down the line. Tube, circuit, ventilator. It's a safety net that always puts the patient first.
And I want to leave you with this final thought. It is so tempting to blame the machine, to think the technology is failing. But the truth is, ventilators are incredibly reliable. They usually don't fail. But you know what does? Lungs and airways. They change, they get worse. So if you can learn to respect the alarms not as a problem, but as an early warning system, you'll transform them from a source of stress into your most valuable clinical tool. So the next time that alarm sounds, what's going to be your first move?